Welcome back. Before your final session of the day, I want to remind attendees to complete the symposium evaluation, which can be found at the evaluation tab at the top of your screen. The link should also be pasted into the chat box. I'm really pleased to introduce Rakesh and Sandra Jain. Dr. Rakesh Jain is a clinical professor of psychiatry at Texas Tech University, School of Medicine in Midland. He also has a private practice in Austin. Dr. Sandra Jain is an adjunct clinical affiliate at the School of Nursing at the University of Texas, Austin. She also has a private practice where she focuses on wellness and the impact of positive psychology on patient outcomes.
Hello, dear colleagues. We are very excited to present on a topic very under-discussed in our community, which is de-prescribing. And the title we chose was Saying a Long Goodbye, De-Prescribing for the Thoughtful Clinician. I hope that title intrigues you. My name is Rakesh Jain, and I'm a clinical professor in the Department of Psychiatry at Texas Tech University School of Medicine in Midland, Texas.
Hello, everyone. Glad to be with you, Rakesh. My name is Sandra Jain. I'm an adjunct clinical affiliate at the University of Texas at Austin School of Nursing, and I also have a psychotherapy practice in lovely Austin. We're so glad to be with you today.
Sandra and I have been professionally working together for 26, 27 years, and this issue of de-prescribing has, it's been an issue in our practices, just as I'm sure it's been in yours. So we're looking forward to sharing the science and some clinical wisdom with you. Our learning objectives, we have 3. The first is to look at the emerging definition and definitions of de-prescribing and which steps do we use to explain it to our patients. Number 2, we will work on augmenting our skill set to make sure de-prescribing has a high chance of success. And then finally, we will look at specific medication classes that Sandra and I have patients on that we really could improve our skill sets in order to increase the benefits of de-prescribing. So to do that, we actually have brought a case for you that Sandra and I have shared. Sandra?
Sure. So let's take a look at the case of the doubting Thomas. Thomas, 27-year-old UPS driver. He's been our patient for 5 years, came into treatment for panic disorder and generalized anxiety disorder. I want you to know he had multiple panic attacks a day, clearly uncontrolled. So he was offered immediate treatment with alprazolam with significant help, even to the point of full remission for the panic attacks and almost full resolution of his GAD symptoms. Now, he'd been on a stable dose of alprazolam, 1 milligram TID for 4 years. But because of the pandemic, as you might guess, his workload, stress increased significantly. And on his own, he started taking an extra 1 to 2 milligrams of alprazolam each day. So this is what happened. He called the clinic requesting a refill of his medications. He wanted an increase in the dose. So, as you might guess, clinician gets very irritated, is frustrated by him, quote unquote, taking too much medication without the prescriber's permission, and communicated to Thomas through the nurse, you got to cut back on your medication or I won't be your doctor. So Thomas in turn gets very frustrated. And this is what he's saying, I'm not being understood. He agrees that he's taking too much medication, and what he wants is advice on how to reduce his dose. So the clinician, again through the nurse, tells him, just cut it down. So Thomas reports that he tried it for a week, it didn't work. He goes back up on the dose on his own, and as you might expect, he runs out of his medication before his next appointment. So 4 days after he runs out of the medication and 1 day before his appointment with the prescriber, he suffers a grand mal seizure while on his driving route as a UPS driver, and he's brought to the emergency department. And the emergency department doctor calls the treating clinician and asks him what happened. And it was at this point that Rakesh and I were consulted because we do want to know what happened with this patient. Was the de-prescribing that was conducted with Thomas done in an appropriate fashion? So we bring this case to all of you so we can think about what can we learn from this particular case.
Very impressive case, Sandra. So as you can see, there are challenges at multiple levels of Thomas's care. Multiple. We can't just look at the ultimate point as the issue, that being the grand mal seizure. What happened? So during our presentation, we will lay out a case how we can prevent catastrophic and subcatastrophic challenges like Thomas faced. So de-prescribing is an art backed up by science, exactly like prescribing is. And just think about it, how much time and energy we as prescribers and you as a non-prescribing mental health professional do exert in better understanding our medications. That's great, but we also must learn the art of leaving medications with elegance and style. That's why saying a long goodbye well is an important skill set. So I will define de-prescribing for the 21st century clinician, and then Sandra, if you want to offer a couple of thoughts. The simple definition is quite simple, by the way. It's just a process of medication removal or dose reduction. That's all you have to do, because the goal is to keep the benefits and reduce the harm. But the modern definition is much more holistic, and I suspect you will embrace it. This is a process of going through the patient's entire medication list, looking at the clinical situation, looking at life circumstances in a longitudinal fashion, and only then creating a comprehensive definition and a plan of de-prescribing. And this requires 4 steps. So it's an organized process. It's not half-assert. It's not do this and see you later. It's actually discussed. Number 2, it has oversight. Oversight by one of us in the healthcare team. It could be whoever. Number 3, the goal is to improve something. It's not just to de-prescribe for the sake of de-prescribing. It could be to reduce pill count. It could be to reduce side effects. It could be because the medication is no longer necessary. And number 4, this is where the modern definition is so useful. Think of the entirety of the patient's physiologic and psychologic status. Think of the stage in life and what are their actual goals. Okay? So, Sandra, do you have any thoughts on the modern definition?
You know, I think, Rakesh, this is what comes to mind, that as a non-prescriber, as a practitioner of psychotherapy, I see us in the true ultimate collaborative care model, because we see our patients more frequently. We spend more time with our patients traditionally. And so we learn about adverse events. We learn about adherence or lack thereof long before you may know what's happening. So I see us as sort of a conduit. We work really well in tandem. So if you are not a prescriber and you hear this conversation about the art and science of de-prescribing, don't stop listening. Really tune in, because here's our chance to really help our patients together.
I think that's extremely well said. De-prescribing isn't just for the prescriber. It's for the entire team. And that includes prescribers and non-prescribers. And here's a wonderful rainbow model for considering de-prescribing in patients. So clinical, we'll start with that. What's the benefit versus harm of staying on a medication or saying goodbye to a medication? What are the financial costs to it? What is the physical aspect of it? And Sandra, maybe you can talk about the psychological and social issues that surround de-prescribing.
Absolutely. So psychologically, we want to meet our patients where they are. We want to be curious. What are their beliefs? What are their attitudes about a medication or medications? And the same is really true from the social standpoint. We want to ask the same questions of their family, their friends, their community, their context, because without knowing that, our hands are really tied to engage people in this process of de-prescribing.
So this rainbow model reminds us that nothing can be separated from each other. So the 7 colors in the rainbow, really, they may look separate, but they're connected to each other. And the same way, Sandra and I recommend, when you think about de-prescribing, go deeper than just the medication. Go into the psychological, the social, the financial, the physical aspects of it. That is the modern day 21st century clinicians' approach to de-prescribing. And patients, for very diverse reasons, and clinicians, for very diverse reasons, choose de-prescribing. Number one reason, though, appears to be side effects. Long-term side effects. Patients don't want to deal with that. Short-term side effects. Also, sometimes some of our medications take away the person from the person. Many people say, I don't know who I am without my medications. I want to get to know myself better. They want to find alternate approaches. Sometimes these medications help temporarily, but just like Thomas, you sometimes do get, if you will, harnessed or shackled by your medications. Sometimes the medication is not helpful. It could be for any one of these reasons or a combination of reasons. So my recommendation, and I will hear from Sandra in a second, a biopsychosocial approach in understanding why a patient wants to stay on a medication or wants to come off the medication, but also clinicians. Why are we thinking de-prescribing is a good idea? The biopsychosocial model is the best one. What are your thoughts?
I would say this, Rakesh, in 30 plus years as a psychotherapist, it is the adverse events, the side effects that bring this conversation to light in most practices. But I would suggest this. Let's think about being more proactive. Let's begin to ask the questions around, have you taken your medication? Have you missed any doses? So we just want to be proactive rather than reactive in the process.
Yes, yes. So why don't we do this? I will quickly now offer you a prescriptive way to look at the de-prescribing process, a 5-step path to success. So I'll quickly cover a few slides here, Sandra. Let's review and reconcile the data. Sometimes we think the patient is taking 5 medications. Well, the patient may be taking only 3 of them, or they may be taking something else another clinician has prescribed that we simply weren't aware of. Number 2, let's assess for the risk of adverse drug events. Sometimes that can be done with some accuracy. And then let's look at each medication's value in the patient's current health status. And if we do choose to discontinue medication, a prioritized list is important. Too random thinking, picking a medication out of the hat is simply not a good way to go. And then discontinue and monitoring process, which we're going to talk a lot more about. So when it comes to de-prescribing strategies, there are 3 approaches. You will in a second find out which one our favorite is. Number 1, a pharmacologic strategy, like it was employed in Thomas's case. Stop the medication, cut it down, do it slower, but just do it sort of on your own. It's all about medication. Then the other strategy is psychological. You want to talk about that?
Absolutely. And I would share with you, this could take up an entire presentation because this is where we bring value to this process of de-prescribing, teaching our patients about stress reduction, about mindfulness meditation, the practice. We cannot overlook and not talk about the role of CBT. Anxiety management, sleep management. These are all valuable non-pharmacological, psychological strategies. But I know, Rakesh, you're going to support me on this. The real powerful intervention is the combination of 1 and 2. That is how we can really help our patients in this process of de-prescribing. Would you agree, Rakesh?
I do, Sandra. And I would love for our colleagues to fully appreciate Number 1 is actually quite useful. Number 2 is quite useful. But 1 + 1 doesn't equal 2. It actually equals 3. And if there's one thing Sandra and I will emphasize to you today, it's the combination of pharmacological de-prescribing strategies and non-pharmacological de-prescribing strategies that lead to the highest rates of success. Not because we say so, because in a few minutes we'll show you the evidence that is indeed the case. Now, please recognize that different strokes for different folks do work. For example, if a patient such as Thomas, who we met, is in the ER just after having suffered a grand mal seizure from abrupt withdrawal from his medications, presents to us compared to someone who is beginning to think about coming off, say, benzodiazepines, there's completely different strategies we will use for that, right? So about 1/3 of patients seem to choose to discontinue their medications over a prolonged period of time. We should support that in most cases, 6 months. About a third of the patients within a month to 6 months. Only about a third of patients in a month or less. So cold turkey, almost never in psychiatry is a good idea. Success is often achieved only by slowing down the process of de-prescribing. And I would like to caution you, de-prescribing often is a bumpy journey. It's often a successful journey, but bumps are to be expected for 3 reasons. Number one, it could be because of the pharmacological changes that we bring about when a medication, even a problematic medication, is removed. But the other is a psychological relationship we have with our medication. And the third may be social factors. What are people saying about it? What are their belief systems? So I'll lay out a few things that might be bumps in the road, and you might want to anticipate that so you can address it. Sleep patterns might change, anxiety might worsen, more emotionality is a challenge, fatigue might come in, and even though memory often improves, temporarily it might worsen. Some patients feel flu-like symptoms, and you can also have GI difficulties. What have you seen, Sandra?
As you're describing these bumps in the road, Rakesh, I'm thinking about a number of different patients. As I read the list, I keep thinking, here's the opportunity for us to bring in non-pharmacological interventions, which I know we're going to dig into in just a moment. But think about the patients you take care of, these bumps in the road. I remember one lady we took care of 20 years ago, helping her get off of benzodiazepines, which she had been on for 20 years. And it was over the course of about 2 years. And for another 2 years, she continued to carry the prescription bottle in her purse. She came in and announced to both of us she had gone to the shoreline, thrown it in the water because she had reached the point where she didn't need it there as a psychological support, just in case. So I love this slide. And I think it's a great way to help with psychoeducation, that before we begin de-prescribing, remember that idea about being proactive and not reactive. Share this with our patients. Let them know what might potentially happen so they're really educated and engaged in the process.
I love it. This is not to frighten patients, but to be realistic with them. As you can see, quite a few patients actually had significant challenges with de-prescribing. Now, we will show you some of the techniques that we can utilize to reduce this risk, but de-prescribing can be bumpy. The destination is a good one, but let's be aware, sometimes it can be bumpy. So here are 7 steps to successful de-prescribing. Let me offer those 7 steps, then Sandra, I would love to hear your comments. Number 1, de-prescribing, choose the right time. In Thomas's case, really? Is this the right time to cut back on medications when the man is going through so much psychosocial stress because of all the challenges around COVID? No, the timing was off. So let's make sure the timing is right. Sometimes the timing has been taken out of our hands. The patient is having a catastrophic side effect. That's a different issue. Your hand has been forced, but choose the right time. Number 2, don't just say discontinue X, Y, or Z without knowing the patient is on X, Y, and Z, and maybe even A, B, and C. So compile a list of all the patient medications, sit back, look at it, determine which is in the patient's best interest in terms of risk-benefit profile to recommend stay on it, or to recommend this is what we're going to consider de-prescribing. Number 3, immediately, I hope you're noticing Sandra's approach, which is to engage the patient in a conversation, is important. Initiate the discussion with the patient. In Thomas's case, let's go back there. What was the conversation? Nothing. The clinician didn't even talk to the patient. It was just like, come back, I'm frustrated. That is the wrong way to go. Clearly the wrong way to go. Explore the meaning of the medication to the patient. And you're going, meaning? It's just a medication, it's just a pill. Not so. We all put very special meaning, good or bad, into a particular disease state or a particular medication. Then introduce the de-prescribing conversation to the patient and approach it with honesty, but also optimism. and definitely try and get the support systems buy-in. They can make or break the success of a de-prescribing program. Number 5, most of our patients will be on multiple medications. We have to make sure we identify a medication that is most appropriate at this time to de-prescribe. Sometimes we actually choose the one that's causing the most trouble. Sometimes on purpose, we'll choose a medication that will be the easiest to come off, even though it's not causing the most trouble, just to reinforce to the patient, you are more than capable of coming off medications that you might say, I cannot ever come off them. And then develop a plan. And the plan starts with a start date. It's not right now. It could be right now. It could be tomorrow. It could be a week from now. It could be whatever. The rate of taper is offered to the patient with flexibility if possible. Sometimes a switch to another medication, temporarily or long-term, may be in the patient's best interest. But look at the final point. Agree to a pre-specified monitoring and follow-up schedule. And always tell patients like Thomas and others, if there's a problem, I'm right here. I will help you. And finally, even though that is the plan we laid out, expect the road to be occasionally, perhaps often, bumpy. And with bumpy roads, you monitor, you adapt if necessary. As long as we anticipate ups and downs that are temporary in a de-prescribing are okay, the ultimate goal of actually coming off a medication that's no longer helpful to a patient and potentially harmful to a patient can be achieved. Sandra, do you have any thoughts on these 7 steps?
Well, let me just say, these 7 steps are beautiful. It's a great roadmap for us about engagement with patients and how to do de-prescribing. I'm reminded of this. I have thought about all the times I've worked with patients around this idea of de-prescribing and connecting them with their prescriber. And when I have an idea and I think it's right, it really doesn't matter, because if I can't engage the patient and meet them where they are, this is going to go nowhere. And so I think about the importance of motivational interviewing. I think about the importance of shared decision making and just simple curiosity. And then to go one step further, we have patients engagement. We're on the same page. We have a plan. It's what you mentioned, Rakesh, that if there is a support system available and we've not engaged them, they can derail this plan with just a comment. So it looks simple, but it does require effort and focus and remembering the endpoint. Where are we headed and why?
De-prescribing, if anything, perhaps requires even more of a skill set from the clinicians than prescribing. Prescribing is actually relatively simple. De-prescribing requires us to bring our A game to the table, and Sandra just illustrated why. Sometimes our patients really are, they are on a different page of the playbook. And we need to make sure that we understand each other using the curiosity that you so eloquently described. That's really a recipe for winning, for success, actually. Okay, so we must have all kinds of skill sets, right? So here I am suggesting that we need to know pharmacokinetics well in order to have successful de-prescribing. So let me offer you some information on what I mean by utilizing pharmacokinetic information on various medications to improve our outcomes. So first things first, let's differentiate between pharmacodynamics and pharmacokinetics. We need to know both. As de-prescribing specialists, we need to know both. Pharmacodynamics is what the drug does to the body. Okay? So if you're taking headache medicine, what does the headache medicine do to the body to relieve me of my pain? That's pharmacodynamics. Pharmacokinetics is the complete opposite. What does the body do to the drug? So how does it break down? How quickly does it break down? How sharp is the absorption? How fast is the elimination from the body? All of that is important to the masterful de-prescribing clinician. It doesn't matter whether you are a prescribing or a non-prescribing clinician. Knowing these basics is very important. It'll be my job to really highlight the importance of all of these factors. So these are the basics. Okay, so what are the basics right now? Well, when we take a medication, it could be an injection, a long-acting injection, or it could just be a pill under my tongue. Doesn't matter. All medications follow this rule of absorption. And you can see the curve of absorption. There is Cmax, which is the highest level it achieved. How quickly did it get to its highest level? That's called Tmax. We're going to visit that. And then what's the half-life of the drug? And you're going, half-life? Yeah, half-life is the time at which a drug has lost half of its maximum concentration. It takes 5 half-lives for a drug to be essentially eliminated from the human body. Please remember these important things that I'm sharing with you. All right, so get to know the whole concept of Cmax, maximum concentration achieved, Cmin, the minimum concentration achieved. And the difference between Cmax and Cmin is called the trough window. Tmax, at what time does the medication become maximum half-life? When is it eliminated? And area under the curve. This is the overall drug exposure. Now you might say, oh my God, this is a lot of information. It does seem that way, but once I give you actual examples, which I will do in a second, it'll be a whole lot easier to understand this. And I would love to show you how to hack the pharmacokinetic information to improve patient outcomes. You folks ready? So let's break it down. Let's break it down. First things first, what goes up must come down. We can all remember that, can't we? So pharmacokinetics in a nutshell is what goes up comes down. I need to know, how high does it go? How quickly does it go there? How quickly does it fall off? See, pharmacokinetics is simply not that complicated to understand when you break it into pieces. And why are we doing this? Are we doing this just for the sake of academic interest? No, 2 things. We're trying to learn about pharmacokinetics to optimize effectiveness and to minimize tolerability issues. We will give you examples in just a second. Okay, so Tmax, time point when a drug is at its highest concentration. So I'll give you examples. May I do that? So you have a patient who's having panic attacks, let's say like our patient Thomas is. Would you give a patient a medication that takes 5 days to get to maximum level? Or would you give them a medication that might take 15 minutes, maybe an hour? See, it's not just how high you go, at what point do you get to the maximum concentration that matters. Let's talk about long-acting injectables. If a patient is receiving a long-acting injectable with the maximum concentration comes after 3 weeks, well, what are we going to do for the first 3 weeks? We maybe have to add something oral just to wait for the long-acting injectables Tmax to arrive. I guess what I'm trying to tell you is knowing about individual medications' different pharmacokinetic aspects is very important in both determining efficacy, but also with determining withdrawal. Cmax has to do with what's the highest blood level the medication achieves. What's better, high or low? And the answer is depends. With some disorders, I need it to pick up as fast as you possibly can. With some medications, I want it as flat as it possibly can. And it determines de-prescribing. So if a patient is on a medication that has a high ability to go up and down, they're going to have more trouble with de-prescribing, right? So we're going to put all this together in a few minutes when we look at specific medication classes. Right now, just pharmacokinetically, let's put it together, knowing about Tmax and knowing about Cmax of the individual medication. And please remember, some medications come in long-acting versions, short-acting versions. Some patients take it twice a day, once a day, 3 times a day. It changes things. But at the moment, I would love for you to be passionate about getting to know Cmax and Tmax of the medication or medications that your patient is taking. Half-life. This may be the most important thing for us to explore today. Half-life is pretty much when the medication has been eliminated by 50%. Okay, so that's 5 half-lives. So half-lives can be different from person to person depending on their body size, their age, or even the dose that you're taking. But most often it's determined by the genetic makeup that they have. But having said that, half-lives between different medications are different based on the medication per se. Okay, but the older we get, half-lives often change. It can also be impacted by other medications. If you're taking 2 medications that counteract each other's breakdown, half-life can be increased or decreased. I know it gets kind of complicated, but this one is not complicated at all. So if I'm on a medication with a half-life of 1 hour, within 5 hours, it's pretty much eliminated from my body. But what if I have a medication with a half-life of 1 week? Then it won't be eliminated from my body for 5 weeks. You see why, to a de-prescribing clinician, this rate of fall is very important. The reason why Thomas got into trouble wasn't just because he was on a benzodiazepine. It was on a benzodiazepine with a short half-life. So his blood levels fell very quickly after he ran out of his medications. See, a real life example why knowing about half-lives is so important. What are your thoughts about the pharmacokinetic data that are presented so far? Does it intrigue you?
Oh, hugely. And I will say, for those who are with us today who are psychotherapists and don't have this background, sometimes we have that initial gut reaction of, oh, this is not in my wheelhouse, this is not in my arena. But it is. From this standpoint, we can begin to see how de-prescribing is based on science. It's based on really good information where someone could have taken much better care of Thomas and really avoided a grand mal seizure. What a different outcome for that young man.
And I'm sure the clinician who was taking care of Thomas had their heart in the right place. They wanted the patient to take less medication. They wanted to protect the patient from the side effects of taking too much medication. But because this clinician did not utilize the rainbow model that Sandra and I talked about, because this clinician did not remember the pharmacokinetic rules of engagement, it's the very reason why Thomas ran into so much trouble, and so many of our other patients run into so much trouble. That's why this conversation about saying a long goodbye is so important. Now, some practical tips on de-prescribing of common psychotropic medications. We're going to spend some time looking at each one of them, and we will take our time. We'll take our time. The number one class of drugs that I do think the vast majority of American clinicians are challenged by are benzodiazepines and Z-drugs. So let's talk about that. Number one, there is no such thing as a single benzodiazepine or a single Z-drug, okay? Each one of them has their own potency and each one of them has their own half-life. Please, if you're going to prescribe a benzo or a Z-drug to a patient, or the patient comes to you on it, we must know that so that catastrophic outcomes like Thomas's don't happen. Okay, so de-prescribing benzos, the following are potential options. Some of them are better than others, but number one, stop it completely. You know what? Some patients handle that just fine. Not the best way to go, but some patients can and choose to do that. Number two, taper at a rate of your choosing. Number three, know that number two may not work. So recommend CBT to start out if they're taking the benzo for insomnia. Well, can we first get them to understand CBTI before we begin the tapering process? Sometimes that increases confidence. Number four, which is our favorite, which is combine. When in doubt, the rule to follow is to combine. And then finally, reducing benzos, you can use the following approach. You can use the same benzo that they are on to use it to taper, but sometimes you can switch them because it's so necessary to a longer half-life benzodiazepine and use that to create a switching paradigm. Particularly with alprazolam, it has proven to be too difficult to use that drug as the tapering mechanism. Sometimes you just have to switch to a longer half-life drug. It could be something like lorazepam, though clonazepam, diazepam, which have longer half-lives, are often better. So there are a huge number of options. But having said that, for that particular patient, for that particular clinical scenario, wisdom in prescribing and de-prescribing is very important. Do you agree, Sandra?
I agree. And may I take just a moment to
Yeah.
share a particular study that speaks to the power of CBT in the role of helping with de-prescribing. So this was a Canadian study where they had patients enrolled who had been taking a benzodiazepine at night for chronic insomnia. They've been taking it nightly for more than 3 months. And so there was the group that got CBT, de-prescribing, tapering, and then just the tapering group. And I want to give you the data at 3 months. At 3 months, after an 8-week CBT session run by a psychologist, this is what they found. Almost 80% of those who had the combination of tapering and CBT had successful discontinuation. I mean, it's quite remarkable compared to those who just had the tapering. They were at about 38%.
Wow,
that is a
difference.
huge difference.
Yeah.
So we've got data to back up why we love the combination of tapering plus CBT.
Yeah, education is power. But CBT is so much more than education, right? CBT is teaching of new skills, new ways of looking at things, counteracting some of the, if you will, challenging negative beliefs a patient may have. So yes, we are one more time asking you to consider combination approaches. And you might say, but I don't have a CBT trained therapist in my office or in my city. Worry not. Digital medicine has really come a long ways, and there are CBT programs online. If you're interested in learning more about it, just ask us during Q&A and we will guide you towards them. Okay, you want to learn more? Want to learn more from really, really good resources? Why don't you consider going to this particular YouTube video? Now you might say, you refer me to a YouTube video for medical information? I am actually, and here's the reason for it. This is by far the very best set of guidelines we have ever seen. These are the Canadian De-Prescribing Network guidelines. It actually offers algorithms we can follow. And the website is actually on the right side, but if you want to learn about it in a quick, succinct, but clinically accurate way, the YouTube video from this organization is actually extremely useful. Let me back up for a second. Every generation makes its own mistakes. The generation before us, phenobarb was commonly used, and it took us decades to reduce the impact on American society, the negative impact. A lot of people died because of it. Marilyn Monroe, for example, died because of an overdose on a phenobarb prescribed by her clinician for insomnia. Benzodiazepines are very useful medications, but having said that, there's a large number of people who are on it for longer than they should be. They are on it at doses higher than they should be, and are being harmed by them in other ways: falls, memory problems. A conversation about de-prescribing with them, if handled with care, gentleness, with this deep scientific knowledge, can often lead to successful taper and to the betterment of the patient's life. Okay? So now we will move on to discussing another class of medications called Anticholinergics that are also way overprescribed in America. And we'll talk about the reasons for the overprescribing and what we can do to help such patients out. So Anticholinergics were initially, 30-some years ago, recommended to be used along with antipsychotics when you started the medication. So when people were taking medications like haloperidol, perfenazine, with a high risk of EPS, high risk of dystonia, I was actually taught that combine them. And then over time, you can get rid of medications like cogentin, benztropine, or Artane, or Benadryl. Remember those times? If you're my age, you definitely do. But with the advent of newer classes of medications, combining them with anticholinergics has become antiquated. But the problem is, I can redo that. So, okay. You okay? Need some water. Let me just take a quick sip. Good. Good. So I'm sure, Amanda, you can edit that. I'll start out with this slide again. And here we go. 3, 2. And now let's turn our attention to de-prescribing anticholinergics. So anticholinergics, about 30 years ago, were widely recommended to be used along with typical antipsychotics because the risk of EPS was so high. But that is no longer recommended because we don't need it. And anticholinergics come with a very heavy price tag for our patients: weight gain, sedation, cognitive difficulties, and here's the fourth one: it can actually increase the risk of developing tardive dyskinesia. And many patients were started on it sometimes decades ago, and they're left on it. They're left on it for reasons that are not quite logical. And all these side effects are happening. And patients often get, yes, I'll say it, they can often get addicted to anticholinergics. And by addicted, what I mean is, every time they try to come off it, they actually have profound withdrawal symptoms. So the clinician and the patient thinks, oh, I feel much worse after I stopped my Cogentin, which can only mean I need to stay on it. See how this trap is set for the patient? Because sometimes when people are on anticholinergics like Benadryl, they can no longer sleep without it. So be careful. If you're going to use anticholinergics, it's probably best to use it only for 2 to 3 weeks and already have a de-prescribing plan in mind before you go into battle. Okay? I do one more time want to say anticholinergics are a hidden epidemic in psychiatry, and I urge you to think about the challenges of doing so, because dementia does appear to be another risk factor of chronic utilization of anticholinergics.
You know, just to add, Rakesh, I love what you said about being proactive rather than reactive. I know we inherit a lot of patients who have been on these meds for a long time, but if we're able to have a plan in place before, beautiful.
Yes. So the suggestions that I would offer you as it comes to de-prescribing anticholinergics, it's exactly the same way that we do other classes of medications. Follow the rainbow. Think of the physical. Think of the financial. But think of the psychological and social factors as well. Rules don't change just because the medication is different. The rules are always the same. And once with the patient, we've had a conversation, and with anticholinergics, the challenge may be the patients may really have serious mental illnesses and may be less able to cognitively engage in a conversation with you. So they may have to be gently guided into why you're saying that Benadryl you've been on for 35 years, I want to gently reduce it. They might fight you on it unless we help them understand it. So what are the steps we can take? Same thing, we can abruptly stop it. Terrible step, but that's an option. We recommend against it. Number 2, taper the dose slowly. But the best way to go is to take a harm reduction approach, okay? So there you actually offer them psychoeducation, get a buy-in, perhaps even set a start date that's not maybe today. Maybe tell them, hey, we'll start that in a week, so that the level of fear and concern is reduced. If they're taking their anticholinergic for reasons such as anxiety or insomnia control, let's find other ways to help them with it. And that's when we taper it off. Now, most anticholinergics have a long half-life, so you don't need to switch to another anticholinergic. You can just do it using the same medication. Take your time. If it takes you a month, if it takes you a year, if it takes you 2 years to come off even a modest dose of an anticholinergic, that's fine. If there's no other option, it is so much better to take a harm reduction approach, which is gradual, gradual, gradual. And you know what? Sometimes the patient might say, I've cut the dose down by 75%, but I can't go any further. I don't pick a fight with them. I congratulate them on what they have done. And then I say, we'll deal with that other 25% down the road, but I'm proud of what you've achieved. That kind of coaching approach, harm reduction approach, can be very helpful.
And let's not forget the rainbow, social, the support, the family, because if patient comes back and says, this is what we're doing, it can be destabilizing to the family, a fear of, we're going to go back to the way things were. So engaging them, having them part of the process.
Oh, I'm so glad you made that point. I had not emphasized enough. As much as we can, pull in the entire team to help us in the de-prescribing process. So with the patient, it might be their spouse, their significant other, could be their brother, sister, dad, mom, children. We all as human beings have an opinion. But what if you have a patient living in a group home? Well, guess what? The staff may believe that the patient is doing well because of X, Y, and Z sedating medication, and they might fight you subtly to have a patient de-prescribe a medication. Bringing them onto your side with the same gentle approach that you're recommending dramatically enhances the chance that we will have success. So these are the skill sets of a de-prescribing clinician. As you can see, it does tend to bring out the best in us if we really employ all those skills. Antipsychotics. Let's talk about that. That class of medication often, not always, often is in need of our de-prescribing thought here. Now, with antipsychotics, there's an added burden. The added burden is sometimes the patient wants to de-prescribe, but we, as caring clinicians, want to actually talk them out of it. So they might say, I'm doing okay, even though manifestly they're having hallucinations and delusions. It's better to understand why. It could be because of side effects. It could be because they don't understand their disease state. It could be because of lack of efficacy. So de-prescribing actually with antipsychotics is often contraindicated, but not always. Not always. In many situations, particularly when it's a mood disorder, then antipsychotics may need to be de-prescribed. And abrupt stopping, almost never a good idea. I want to assure you, almost never a good idea. Taper the dose, but I again urge you, and Sandra, I'm sure you'll agree with me, taking a harm reduction, combining it with non-pharmacological techniques, and then gradually, in most cases, a gradual taper down, or sometimes a cross taper. If you're going to switch a person to another medication, another antipsychotic, a cross taper may be necessary. Again, please explore the meaning a patient and the support system places on the medication. Sometimes it'll surprise you. Sometimes people will believe things about their medications that are unique to them. And I got to know that so that I can help them with it. I've actually had patients say, it's because of this medication, I'm losing my hair, for example. That's their belief system. Or it could be because of this medication, the police no longer picks me up like they used to 3 times a year before because I was out wandering and yelling at people. What are the patient's belief systems, negative or positive, about a medication? Profoundly affects how we de-prescribe a medication. Now we come to a class of medications that are easily the most prescribed of all medications in the psychiatry world in America, and those are SSRIs, SNRIs, and other antidepressants. Okay, so let's touch upon them. So all of these medications have very different half-lives. So that would be pharmacokinetics, right? They also have fairly different receptor binding profile. In other words, what it does, the medication does to the human brain and body, that's pharmacodynamics. I've got to know both. But no doubt, if I'm in the process of de-prescribing, knowing both may be essential. I'll give you a couple of quick examples. If I go from a very high serotonin receptor blocking drug with a short half-life, and I switch them to a medication that has very low serotonin receptor binding and has a long half-life, guess what? I'm leaving them naked and vulnerable to serotonin withdrawal for the first few days. And that could lead to the patient saying, I need to stick to medication 1, even though that's the wrong decision for them. And I hate medication 2, not because it's a bad medication for them, but because they had withdrawal symptoms from medication 1. Do you see what I'm saying to you? Getting to know pharmacokinetics and pharmacodynamics makes us 10 feet tall as clinicians. And if a non-prescriber doesn't have detailed information on it, guess what? They can call the prescriber if de-prescribing is being considered to discuss it. Or, much simpler, is to actually go to your Google, type in the medication's name, and say package insert. So if it is you're looking for sertraline, which is Zoloft, and you want to find out these details, you just type in sertraline package insert. Guess what? The actual package insert opens up, and then you can look at the pharmacokinetics and pharmacodynamics. Having said all that, be careful with de-prescribing antidepressants. Careful. Don't just abruptly stop it for 2 reasons. They can have a relapse and recurrence of their mood difficulty. Just the rate at which we stop medication, Sandra, can actually increase the risk of relapse. The human brain does not like for medications to be withdrawn too abruptly. It does not. Number 2, there are withdrawal symptoms to our medications. Almost all of them, when they're stopped, particularly abruptly, can give people lots of side effects. You saw me give you the list. It can be more anxiety, more sleep, more tearfulness, more fatigue. All of these are bad things. And patients go right back to their medications thinking, oh, I need it. Well, no, that may not be the case that you need it. It's just that coming off it is so painful. And you didn't know it was coming off the medication that gave you those side effects. And then you sort of shackled to a medication you actually did not need it. You see my point, don't you, Sandra?
Absolutely. The other thing that comes to mind is even with slow taper, what I've seen with so many of my patients, I'm guessing many that are joining us today have seen it as well, is the last little bit of an SSRI, that there's something about that, I refer to it as the last little pinch, that can be more difficult than the entire process. I mean, could you speak to that?
Yeah, so because of receptor binding profile, thank you for making that point. If you break the dose of the medication down roughly in your mind into quarters, so if a person is taking, I'll make this up, 10 milligrams. So 7.5 to 10 would be the first, the top quarter, 5 to 7.5, the second one, the third would be 2.5 to 5, and the fourth would be 0 to 2.5. Because of the way receptors are occupied in the human brain, it's the bottom 2 quarters, but particularly the bottom quarter, that's hardest for the brain to let go of. Not the person necessarily, but for the brain. So Sandra's making a very good point. When you are tapering, it's okay to proceed a little bit faster for the first half of the taper process, but the second half, you really want to slow it down. So jokingly, Sandra and I often call it the complete opposite of country western dancing. So in country western dancing, you do it slow, slow, quick, quick, right? Am I right on that, Sandra? But you want to do it the opposite when it comes to de-prescribing. You're welcome to do it quick, quick, top quarter, second quarter, but slow, slow for the third quarter and then the final quarter of the medication left. It will go better that way. How long do you want to take? As much as the patient will allow you to. We have found repeatedly, and the data supports it, a slower process, harm reduction, especially when you combine it with things like CBT and exercise program and mindfulness practice and all other wellness interventions, really does increase the chance that a patient will have success. Think about it that way, will you? Okay. So now we move on to lithium and mood stabilizers. And you're going, lithium? There's no withdrawal with lithium. What are you talking about? There is. So there's actually a wonderful study from UCLA, from Lori Altshuler, who has since then passed on, that does tell us that patients who are abruptly withdrawn versus patients who take up to 2 weeks to withdraw, if you follow them for 6 months, there is a full 50% difference in the ultimate relapse of bipolar disorder. So it wasn't stopping the medication that was the risk factor for bipolar disorder coming back. It's the rate at which you stop the medication. And I'm only talking about 2 weeks. As a result, all of us who are together today, we must appreciate while prescribing is an art, de-prescribing may require special thought, may require special skill set to make sure the patient and we are on the same page, and gentle and slow approach may be the key to success. And that's true with lithium and mood stabilizers. And if you're saying, oh my God, this list of de-prescribing tips and tools are near exactly what I have seen with other medications, you would be right. We do not need to recreate the wheel at all for different medications. It's the same rainbow approach. Get to know the various medications the patient is on and to look at their side effects and the potential benefits, followed by what does the patient think about those medications? What is their belief system? What does their family think about their medication? And then, as Sandra has said, we need to think about the psychological and social aspect of their beliefs one way or another. And the same is true with lithium and mood stabilizers. So many patients believe lithium is a lifesaver for them. So many people believe lithium is toxin for them. I need to explore that. And if I don't explore it with kindness and gentleness, patients learn very quickly to look at us, keep their mouth shut, smile and nod their heads, and an important opportunity to engage them is lost. So here too, strongly recommending based on very good data, do not abruptly stop. If there is a reason to reduce the dose or stop the medication, that often happens. We may want to be wanting to get away from lithium to something else. Please do it with the same skill set, the taper, maybe even cross taper. And if they're getting other benefits from their mood stabilizers, such as could be sleep, let's make sure those needs are addressed. Any thoughts, Andrea?
I'm thinking about sort of this template, sort of a roadmap of how we approach this regardless of the drug class. So kind of the foundational rule, don't stop quickly, go slow. But then I'm thinking about every drug class, all my patients over the years who have on their own, because of side effects, just stopped. Come in, did you talk with your prescriber about that? No, I did not. I was tired of doing it, so I just quit. They're reporting side effects. My takeaway is this: to the template, I'm thinking we also add early on, be proactive, maybe during the informed consent, talk about this, because there's the opportunity to say, don't stop on your own. Talk to us first. Talk to your treatment team. Yeah. Beautiful. I love this roadmap approach.
Yeah, it really has been useful, Sandra. It's a bit like, may I use another analogy? If you go into war against a worthy adversary, like a psychiatric illness, make sure you have an exit strategy when you go to war. And in many patients, though not all, obviously, medications aren't necessary for an entire lifetime, or the medication's effectiveness may wane over time and we may have to switch, right? So this de-prescribing is a very essential skill set, and only now are we beginning to train our younger colleagues, our nurse practitioner students, our PA students, our MD and DO students in the fine art of de-prescribing. So in conclusion, if we might offer you a few thoughts, Sandra and I will do it together. Let's go back to where we started. Redoing de-prescribing with Thomas. We'll use him as an example, but only as an example because so many different things could have been done differently. But we need a model, though. We can't just recreate a model for every single Thomas. What I recommend we do is, let's go back to the basics. Look at the left-hand side of the slide. There are 5 elements, the 5 elements of the rainbow we must consider. Clinical, first of all. Benefits versus harm ratio. What is happening in this particular patient at this particular time? Appreciating that it may change over time. Number 2, psychological, social. I'll let Sandra comment on it because that's her area of expertise. Financial, what's the cost? What's the access? Has the medication come off their formulary? Is there another reason that they would like to switch? Physical, what is the pill burden? How difficult is it to take this medication? Is refilling a medication a challenge? Is adherence a challenge? What are some of the side effects? Sandra, you want to comment on the psychological and social aspects of this rainbow?
Yeah, I think only to repeat, Rakesh, what we've said throughout this presentation, that we must meet our patients where they are. Even if we feel like we are 100% right and we are ready to get to it, if we have not met them where they are, it will not go well. And I share with you, Rakesh obviously knows this, I'm a type 1 diabetic, 33 years and counting. And the truth of the matter is, early on, when treatment team would lecture, not in a mean way, but they thought they were doing what they were supposed to, but it was more like, this is what you need to do. This is how you do it. No one listened. They didn't understand what my fears were, what my concerns were, even about finances, insurance. How do we pay for this? And I'm sure time was a factor. But it led to about 5 years of kind of shaky compliance because I wasn't engaged. Here's a chance by following this and the rainbow. I love that idea of follow the rainbow because it's very hopeful and optimistic. Meet our patients where they are. Go back, read about motivational interviewing, shared decision making, because that's where we start. Really a path to much better outcomes.
I love your rainbow. Yeah, there may be a pot of gold at the end of this rainbow for the patient. If the patient wins, we win. Thomas obviously did not get a pot of rainbow at the other end of his journey with de-prescribing that was forced upon him. But let's see, what were some of the things that could have been done? So what were some of the new approaches we can take if we followed this emerging paradigm of de-prescribing? For example, direct connection with him. I think if the clinician had spent 2 or 3 minutes talking to Thomas, he or she may have changed their mind on what to recommend. Number 2, understand why the patient is saying things like, I can't make it without the higher dose of medication. What is it? Is it the medication's less effective? Is the stress gone up? Is that a new disorder has crept in? That can happen. What actually has happened? Could I have offered this patient something else? Could I have switched the medication? Could I have been more sympathetic? But the patient, Thomas, could also have been abusing the medication. So you have a right and an obligation to make sure that's not occurring under your watch. But how will we know that without communication? Then we could educate him about his concerns. Say, hey, you're going up on the dose in a way that could be harmful to you. Can we look at other ways to do it so that we don't go up on the dose, yet we can help you? And then finally, if there was a reason to switch him to a different class, or slow taper off his medication, individualizing to his needs. The man's a driver. He has needs for cognition. He has needs for good motoric control. And to fit it into his life would have been a better. And if this clinician did not feel they had the competence in that specific area, they can definitely refer to a colleague who has greater expertise. But all those opportunities were lost in Thomas's care. So allow us to emphasize the following one more time from this beautiful article written by actually a cardiologist, not a psychiatrist, but every clinician, no matter what their specialty is, prescriber, non-prescriber, must appreciate this. De-prescribing is an important component of the process of good prescribing. We cannot go into battle with psychiatric illness with medications without knowing how to come out of the battle. Otherwise, we're stuck in the battlefield, if I can keep using the analogy, for far longer periods of time than we need to. this skill set that Sandra and I are recommending is absolutely crucial. So let's just end with practical tips, and I'll offer you a few thoughts, and then we will end with what Sandra's wisdom is: choose the right time. De-prescribing is not something to pull out of a back pocket just because the thought just crossed our mind. Choose the right time. There may be times where your idea is a good one, but perhaps waiting a month or two may be better. Number two, let's know all the medications the patient is taking. De-prescribing doesn't happen in a vacuum. Number three, pull the patient in. This is not a solo journey. This is a team effort. Let's initiate the discussion with the patient, and then, if possible, bring the support system in. In fact, almost always, please try and do that. Identify which medication would be most appropriate to taper. Is the one that's causing the most harm? Is the one that will be easiest for the time being? Let's have that discussion with the patient and in our own minds, and then develop a plan with a start date, a rate of taper, but be flexible. In most situations, please don't have a rule that is set in stone. You must be off this medication in 2 weeks or 2 months. Say, that's my expectation, but I'll be flexible with you. That gives patients confidence that they can do it. And very often, patients want to prove me wrong in a healthy way. They'll say, you said it'll take 2 months, but I was able to come off it in just a month. And I go, well, you're a very special patient. You did it very well. I'm very proud of you. All those coaching techniques can be very helpful. Sandra, what are your thoughts on this slide?
You know, again, I love it. It's a great outline. But a couple of things to remember: be proactive, not reactive when the opportunity presents. Sometimes we're not always that lucky. We do have to react. But try to invest the energy on the front end before you begin prescribing with a particular medicine. That investment of time and energy on the front end will certainly save you on the other end of the equation. And I think really from what we've talked about today, it's meeting the patient where they are and really being patient, that they will not always, if ever, operate on our timetable, and that patience will pay off. And finally, absolute curiosity about what their belief system is about medication. You know, sometimes we think we've heard everything, but I will tell you, this conversation sometimes will unearth things that patients believe about medicines. You'll kind of shake your head like, really? I've never heard that. So be curious, see what you can learn. And that really begins to strengthen that therapeutic relationship with our patients. And that is a win-win for all of us.
It's a win-win. De-prescribing often is a win-win for all of us. Those are the wonderful words to end our conversation on. So thank you very much for letting us present on a topic that has been under-discussed in the field of mental health, and we are looking forward to a vigorous Q&A with you. Thank you.
We'll see you soon.
Well, Dr. Jan and Dr. Jan, that was as expected and as promised. It was wonderful. Thank you so much. Cliff, I'm going to let you have the question in the question and answer box, but I have a first one. So, you know, in the field, we've been talking about combination therapy for a long, long time. And Sandra, you really broached the subject of combination therapy as we de-prescribe too. And I love that. So my real question really is, when did you all get the aha moment to say, we need to be combining combination therapy, CBT, as we take people off of certain medications? When did that just dawn on you all?
May I?
Yeah.
I will say this, it was an aha moment when probably 7 or 8 years ago, Rakesh and I began presenting together on benzodiazepines. And we dove into the data because we didn't want to pick a side. We wanted it to be fair, balanced. We wanted to look at the good, the bad, and the potentially ugly in that particular medication class. And the data was so positive on the combination, including non-pharmacological interventions, specifically CBT, but also just plain psychoeducation. Powerful results. And it was at that point that we realized, okay, we must talk about both. Rakesh, how about for you? What was your aha moment?
Yeah, I think it was humility or being humbled by me taking an overly medication approach to coming off a medication. I mean, on paper, Ben, it made sense. You're on medication you don't want to be on. I don't want you to be on it. Let's just cut it down. But the outcomes were not good. So Sandra and I started exploring what were some of the drawbacks. And I think what we did, the mistake we made is we took the human being out of the equation. And I do think non-pharmacological techniques, Ben, bring the humanity back into the process of psychopharmacology. So when we combine that, people were not only more empowered, the whole process went smoother. There was a better alliance, both at the beginning, during, and afterwards. And it's to the point we simply no longer try and differentiate between pharmacological, non-pharmacological. They really are a combination approach that ideally helps the individual de-prescribe successfully.
Good, thank you. Cliff?
Okay. Well, I was glad to hear you say something about humility. We had a wise attendee who wrote, be humble. The prescriber and the therapist need to have humility. And I've long tried to teach that humility is actually the path to medical authority or any clinical authority that can be believable. Well, and the person who brought that up also characterized this: avoid using overuse or inappropriate use, especially using the word abuse, and find some other way to describe, maybe you've been on the medicine longer than usual, or maybe we should look again at this. So I thought I'd just see what you thought about that. And also another point, so the humility and don't use the word abuse. I thought it was great that I heard, Sandra, you say something about motivational interviewing, along with CBT, mindfulness practices, exercise, sleep hygiene, and all the other things that we need to be helping people with. And it reminded me that earlier this year, I heard a real prominent psychiatrist in a major national meeting talk about how when the clinician uses motivational interviewing, it not only helps the patient enormously, it helps the clinician, and it helps the clinician avoid burnout. So I wonder if you could talk about these kinds of humble approaches to listening to your patient. And if you just want to say, I agree, get to the next question, that would be fine too.
No, Sandra, this one, I'll get the ball rolling, but I would love to hear your thoughts as well. Humbleness, I think, should be born out of the fact that it's the truth. We don't know everything about either psychopharmacology, and we don't know about the person who's taking the medication. But I would love to recommend pairing humility with curiosity. So just being humble, I think, is just the entry into a good relationship. But after that, where do you go to? And I think it ought to be curiosity. And finally, I think it ought to be individualization. When you combine those three traits, I do think patients or clients feel very empowered. That while I may not have all the answers, I do bring with me a set of skills and an expertise that could aid you in making the best decision for yourself. And Sandra really has taught me a lot about motivational interviewing. But I'll say this before I turn it over to her, Cliff. Utilizing motivational interviewing allows me not to have to play the pseudo expert that sometimes I feel when I'm encountering a difficult patient or a difficult clinical scenario, because by using motivational interviewing, I'm able to share the decision-making and also truly perfect the art of appropriate humbleness and humility. And I feel less burdened when the clinical scenario is challenging and I don't have all the right answers. So Sandra, what are your thoughts?
Yeah, beautifully stated. As I was listening to both you and Cliff, I was reminded that in the previous presentation on psychedelics, we had included a slide at the end, and the title was "Curiosity is Medicine?" ? And I think it's a nice circling back to our first presentation. That to me, maybe we've hit upon something quite remarkably important today, and that is we can take humility plus curiosity and have found a really nice way to meet our patients where they are, rather than us telling them where they are, being the expert, like you said, Rakesh. And there's something about when we release that need to fix everyone's problems and know exactly what we should be doing, there is a release of some of that burden, that responsibility. And I think, Cliff, to your point, that's why it doesn't feel so burdensome. It doesn't feel like work. Then it is much lighter, and it is more of a collaborative, shared relationship. And if I could, so that we don't miss commenting on the attendee who talked about sort of the harshness of the word abuse. I know from previous conversations with Rakesh, we are like-minded on this one. And let me just say, let's think about death by suicide. You know, up until recently, maybe just last year, maybe the year before, the language was that a person committed suicide. And American Foundation for the Prevention of Suicide was a very loud and positive advocate that we needed to change that language. It's not like a criminal offense, like you committed a crime against whatever, right? It's just death by suicide. And it is less stigmatizing, less harsh towards not only the person, but their entire family. So I want to really say thank you to the attendee who made that comment. I think it is, I think we need to be as sensitive to the word abuse in this context as we are to the word committed suicide in that space as well. So thank you for that.
Yeah, may I just offer a quick thoughts to you folks? I think a better word is misuse because it's more accurate. And then the model to use to help people perhaps reduce the dose, come off the medication, is the model of harm reduction. And harm reduction is a completely different concept. It no longer has any morality to it. It doesn't have any pejorativeness to it. It just has the issue of, are you benefiting? What's the ratio between benefit and harm? Has that ratio tilted? Do you have personal reasons to want to do things differently? If that is the case, your goal, dear patient, and my goal, me, the clinician, is harm reduction. Let's just engage in a process that takes out all the other garbage, all the morality that we often culturally put on specific medication uses. Like if I was addicted to caffeine, you would probably laugh and joke with me. Oh, you go to Starbucks 4 times a day, never ever thinking, my God, he's fully dependent on it. But goodness, when someone uses a benzodiazepine more than an extra dose, we immediately flip into, oh, a benzodiazepine addict. When we take that out and focus on it using the model of harm reduction, that entire conversation changes, and patients and we become one cohesive force.
Thank you. Well, and there are a couple of actual pharmacologic questions. One is, and I was proud of the person who asked this, takes some courage sometime to say, I don't know the meaning of something that everybody else seems to know. And so the question is, what's the difference between a benzodiazepine and a Z drug?
Sure, I'm happy to talk about that. So 2 main differences. The name benzodiazepine is based on the chemical structure of the molecule and not its mechanism of action. The Z drugs, the zolpidem, the zolpiclones, their name is based on, again, chemical structure. So they're chemically different structures. But Cliff, if you look at the GABA A receptor, so to back up a bit, the GABAergic system has three main receptors: GABA A, GABA B, GABA C. GABA A is where both benzodiazepines and Z drugs work, but they occupy different sites on the receptor. So there are minor differences, but the differences are fewer than there are the similarities. And I do think because Z drugs got called Z drugs, we automatically abdicated the responsibility to remember at the end of the day, they're GABA agonists. Therefore, they have all the challenges, but they miss out on a couple of things. So if you're having a seizure and I gave you a Z drug, either intravenously or otherwise, they would not work. So in some ways, they're weaker than a benzodiazepine, but in other ways, in terms of sleep induction, they are its equal, and also in terms of withdrawal, they may be nearly the equal of benzodiazepine. So right under our noses, there really does appear to be an epidemic of Z drugs happening that I'm afraid in the next 10 years or so, we may be paying a pretty heavy price for.
And I would tell our attendee that if you look back at the slideshow, you'll see that both of those are addressed on the same slide with the same process there. Another one is, this question was, aren't anticholinergics like Cogentin necessary for first generation antipsychotics? And then the attendee went on to say, this particular person is on Prolixin, but is also taking a second generation antipsychotic along with the Prolixin. So the suggestion was that there might be more than one idea about pulling a particular drug away. The first being Cogentin, and the understanding is by the client, by the patient, is that this is necessary if I'm on a first generation antipsychotic.
So I can start the ball rolling on this. So whoever asked that is clearly someone who's read the guidelines, but the guidelines are from 1970s and 80s. So you're right. Those were the guidelines. APA's guidelines did emphasize, because of the potency of the first generation antipsychotics, typicals that is, EPS, extrapyramidal symptoms, were so common, you might as well start them on both at the same time. But if you keep reading those guidelines, they said also, and if you can, in the first 4 to 6 weeks, try and pull away the anticholinergics. And I think that's a particularly important point. Some people truly continue to have difficulties with EPS symptoms chronically, but the vast majority, Cliff, no longer need the blockade of acetylcholine, anticholinergics, to keep that under control. If we continue anticholinergics for more than 4 to 6 weeks, as I said during my presentation, anticholinergics create their own life. They actually become necessary for the person to fall asleep or control their anxiety. So the individual may actually get quite confused and say, when I stop taking that medication, the one that starts with the C, I feel bad. Therefore, I must continue taking it, not realizing it's no longer for the control of EPS, it's now to help them with sleep. Mm-hmm. So the guidelines actually have changed. So whoever asked that, I would encourage them to look at the more recent guidelines, which, by the way, just came out in December last year. APA put out its new guidelines on schizophrenia last year. And there, the emphasis has shifted quite remarkably. Anticholinergics are appropriate. They are, however, appropriate in as short a burst as possible. And the routine use of anticholinergics with antipsychotics is no longer recommended for all the reasons that I described just a minute ago.
One last thing. One of our very valuable NAMI representatives, Leslie El Sayad, is one of our attendees. And she wrote here at the end, and this is how I'll say goodbye, because it's beautiful what she said. Your process for de-prescribing, your process recognizes that the patient can be an expert about themselves too. So I appreciate that. I thank you for such a good, sort of noble and encouraging talk. And Ben, I'll turn it back over to you.
Well, thank you, Cliff. First of all, Cliff, thank you for being our symposium medical director for 24 years. Appreciate you. You've kept us on the right path, and we've been able to do great things. So thank you. It is time for me to bid a fond goodbye, to be punning, I guess, to the Fall Psychiatric Symposium for 2021. And I need to thank Rakesh and Sandra for all your help and your willingness to participate again this year. We greatly appreciate it. You've done good, as they say here in East Tennessee.